Well, let's now dive into what really is myeloma. I mean, we've been talking about this disease already for 23 minutes, and some of you are very familiar with myeloma, some of you not so familiar with myeloma. So we've entitled this next 15 minutes or so myeloma for patients who are just getting started. So I want to just walk you through some of the very basics of myeloma, but then also talk to you a little bit about how do we treat myeloma. So going to the basics of blood. So, in your body right now, there's circulating your blood, as we all know. And your blood is made up of some solid stuff that we call cells and some liquid stuff we call plasma. And I'm going to offend every hematologist here, by the way, by oversimplifying. So Pete, try not to have a seizure as I share the simplicity of this. But the way I describe it to patients is that you have three kinds of cells that solid stuff that circulates in your blood, what we call red cells, white cells, and platelets. Red cells are just little cells that carry oxygen. Yelek mentioned to us that when he was diagnosed, he was anemic, which meant he had less red cells, which means he had less ability to carry oxygen. I think of these as little trucks that just pick up oxygen when you breathe it in and then go deliver them to the tissues and then come back for more. So they're just little red trucks constantly circulating in your blood. White cells are a bit more confusing. White cells are actually, there's all sorts of types of white cells. And think of them as a big part of your immune system. Like soldiers in an army, they're there to protect you. And interestingly, kind of like we have five major branches of the military, we have five types of white cells. And so these are the ones that protect you from infections and things like that. And then lastly, we have these little cells called platelets, and they are the ones that help you with clotting. I think of them kind of like an ambulance. If I get a cut on my arm or something, they get there first and they patch up the problem as an ambulance would, and then you're kind of, if you will, taken to the emergency department to really fix it up with what we call factors. And all of these three cells that are circulating your blood all originate from what we call the bone marrow, which is the factory of your blood. And that bone marrow is going to become important as we try to think a little bit about multiple myeloma. But even before I talk about myeloma, let me just think about what is cancer. If I had to narrow cancer down to two words, I would say, or three words, it would be identical, uncontrolled growth. You can just picture it a bit more easily with a breast cancer or a lung cancer, where there's just this tissue that's growing. That's really what's happening in all cancers. And usually the body has a balance that lets your tissue grow, but not grow out of control. And it's when that out of control happens that it becomes cancer. The problem with blood cancers is that those very cells, like we talked about earlier, those white cells, the very ones that are meant to protect you are now the ones growing out of control. And that's why we think of it sometimes as a double whammy. So it's not just that it's harder to visualize because they're liquid tumors, but it's even more concerning because those very cells that are meant to help you are the ones that are now attacking you. So myeloma is a cancer of something called the plasma cell. And the plasma cell lives inside your bone marrow. So it doesn't normally circulate in your blood, although some of them can. Most of them live in the bone marrow. And you may not know this, but we've all been talking about plasma cells for the last 2 years. Every time we talk about COVID and maybe someone getting their immunization, getting their vaccination, and we say they're going to make antibodies to protect them against COVID, you know who's doing that? Your plasma cells. That's exactly what plasma cells are designed to do. They're there to make the antibodies that you have to fight off infections. And normally we make good antibodies that fight off tetanus and COVID and whatever else. But here what happens when those plasma cells become cancerous and they're growing out of control, they now make, if you will, bad antibodies or abnormal antibodies. And, we use the word immunoglobulin because, of course, doctors like to use words that patients don't understand. But immunoglobulin is basically the word antibody. And so now when they're abnormal, we call them monoclonal, which just means that they're all of the same type. Remember, what was cancer? Identical, uncontrolled growth. And so now we call it the M protein or the M antibody or the monoclonal antibody. So when you hear things like the M spike and M proteins and all this, it's all referring to the bad protein that gets made. And so multiple myeloma is a cancer of plasma cells. So now instead of making just good antibodies, you make all these bad antibodies. And we're going to see that sadly, those bad antibodies start to attack the body. We've mentioned already some of this, so I won't go in a great amount of detail, but it's about 2% of all cancers. We diagnosed about 35,000 people last year, and sadly, about 12,500 people died of myeloma. The incidence, as we've mentioned, is twice as high in African Americans, with, as I sadly commented already, the mortality being twice as high in African Americans. And so when we see this cancer of the plasma cells, this multiple myeloma, instead of making, as I mentioned, the good antibodies or immunoglobulins, we make these bad ones. And as we've commented before, this disease is, generally speaking, seen more in older individuals, although Jelek just shared with us a story that he was diagnosed at the age of 25, and that we know that this disease is typically in older patients, but we can see it in younger individuals. We've commented on this a little bit already, that it's sometimes really hard to make the diagnosis. You know, patients don't come in with a sign on their head that says, hey, I've got myeloma. You know, Jelek was having this cough for a long time, and it took a while before they were able to figure it all out. He was anemic, which some of our pictures here are meant to show that this individual who's got his head on his desk, which kind of looks like me when I was studying for my medical school exams. But, you know, in this situation, he's exhausted because his hemoglobin was low. One of the characteristic features of myeloma is that people get bone pain, in particular in their back, and you can see the back pain here. And sometimes this causes us to be unable to focus and not have the energy and strength that we typically would. And so we can see here that fatigue, bone pain, and this anemia, as we've described, are the key hallmarks of multiple myeloma. Ultimately, when we formally make the diagnosis, we have this thing called CRAB, or C-R-A-B. I'm not going to go into too much detail here, but we can see in the blood someone's calcium high. We can see renal or kidney problems. We can see the anemia or low red blood cell, as we've commented on, and indeed the bone disease. We've recently added 3 more criteria, which are more technical criteria that I'm not going to spend a lot of time on. And now we call these altogether myeloma-defining events. But people need to have a bone marrow test to look for those plasma cells that are abnormal, and then see what those plasma cells have made cause all of this damage. And indeed, that's part of the challenge here, is we know that African American patients, for example, are less likely to have a bone marrow test to make the diagnosis. And so we want to improve that and find better ways to make the diagnosis. And so when we think about these CRAB symptoms, this is just an image to help you see that this disease is really all over the body. It is a blood cancer, but it affects the bone, it affects the kidney. It can then cause people to be fatigued. Because you're not making as many of the good antibodies, you're at risk of infection. And all of these different things can happen. Most patients don't have every single one of these, but most patients have at least one, if not 2 of these kinds of symptoms. We've also come to learn that myeloma actually is a disease that has what we call a precursor or a premalignant condition. What that means is, believe it or not, up to 10% of us, and I'm of African descent myself, up to 10% of us, whether you're of African descent or not, can have a little bit of this M protein, or this abnormal protein in our blood. It doesn't mean that 10% of the whole population has myeloma, of course not. But as we grow older, some of our plasma cells can become just a little bit off. So we had to draw a line as to how many of them have to be off to truly have myeloma. So we have these conditions, something called MGUS, as you see here, or even smoldering myeloma. These are conditions where there are just a few plasma cells. You can imagine if someone had just a tiny, tiny little abnormality in a tissue that it's not really big enough that we get worried about it. But as soon as it starts to grow bigger, that's when it becomes a problem. And same thing we see with multiple myeloma. So when we think about treating patients, back when Jelek was diagnosed, as we heard, there weren't very many options, and he got some pretty high-powered therapy. But now, thankfully, there are many choices, and Pete and I are going to share with you some of the choices that there are in when someone is first diagnosed, and unfortunately, later on when their disease may come back. And I've just listed here that there are lots of different things that influence our choice based on someone's age and their so-called risk profile, the symptoms that they're having. But I want to put right in the middle, and I know Amy's going to come back to this when we talk about communication, the importance of your preference. It's Thankfully, we have choice now in myeloma that we didn't have perhaps back in the day when Yelek was treated. And so it's important to keep that in mind as we go forward. We also have this encouragement for people to seek, I prefer the word expert opinion as opposed to second opinion, because sometimes that makes it sound like the first opinion wasn't good. But this is a complicated cancer, and many oncologists treat 30, 40 different kinds of cancers. It's hard for them to keep track of all of them. And so we do have resources through the IMF to help people to find someone who is an expert in myeloma who can help them and understand the disease even further. Now, it's impossible for me in less than 10 minutes to tell you about all the treatments in myeloma. I mean, this is a complicated world. And I put this slide up almost just as a reference slide, but in one way, it's exciting. These are a whole series of words that Yelek did not get to see 25 years ago when he was first diagnosed. And here we have all of these new drugs. And trust me, I don't make the names, right? Don't blame me for the unpronounceable names of most of these drugs. But it's just a reminder that we have different classes of drugs, all of which work in different ways to try and attack myeloma. And one of the simple themes that you're going to see in my talk now and in Dr. Voorhees' talk later is we have learned in myeloma that it's really hard to control this disease with one drug, that if we use a combination, we can capture it. You know, we learned even a little bit from our colleagues that treated HIV that in many ways HIV was overcome not because we found one magic pill, but because we found the right combination together to tackle the disease. And so much of what we do in myeloma is combination therapies. So what I'm going to do in my last few minutes here is give you kind of the principles of treatment when someone is first diagnosed with myeloma. Obviously, we're trying to give people a high overview today and not give extreme amount of detail. But let me share these 5 principles and then just a couple of comments about transplant and non-transplant approaches. So first of all, most patients are going to be given a combination of drugs because we've learned that if we get the disease down quickly, we can stop the damage that's happening to the kidney and to the bones. We don't so-called save the best for last. We're using more and more the best therapies that we develop. And I've been involved in myeloma research for over 25 years. And it's been so gratifying to see these new drugs come forward. We want to use them early on so that we can preserve patients' lives and their quality of life for the longest period of time. We want what we call a deep and a durable remission. So whatever measure we have of the myeloma, all those different immunoglobulin measures that we have in the blood, and to some degree in the bone marrow, we want to get it down and keep it down. And that's the concept of deep and durable. We typically start with we typically start with a combination of 3 different classes, as we call them, of drugs, something called proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies. And obviously, there's a lot to say about these, but some of you are familiar with it more than others. But we mix and match from these 3 classes to try and create the so-called cocktail, as it were, that is going to best control the disease. And then we typically decide early on, is this someone who's going to have a stem cell transplant or not? And stem cell transplant sounds scary, but really it's just one big dose of chemotherapy. But before giving that dose of chemotherapy, we collect people's stem cells, as we call them, or cells out of their bone marrow that can grow a new marrow, kind of like seeds. You know, if I want to grow a new lawn, I want to have seeds, and we kind of collect seeds from patients, give them the treatment, kind of like burning the lawn, and then we put seeds down or give them seeds back into their blood to grow a new bone marrow. And we've learned that that can really help patients. So typically when we decide on treatment off the start, we say, are you stem cell transplant, or as we call ASCT, autologous stem cell transplant eligible, or autologous stem cell transplant ineligible? We know that some people, it's not a good idea to go to transplant. As we get older, it's more difficult. As we have more comorbidities, like maybe heart disease or lung disease or diabetes, those things can make it a little bit more difficult. But typically, for those who are getting treated, we give them a combination of 3 or 4 drugs, whether they're going to transplant or not. And we'll share a little bit more about that in the last couple of minutes here. So what I've done to conclude this section is to look at the transplant eligible and ineligible groups and just ask 3 questions for each to try and summarize how we think about treating multiple myeloma. Question number 1, Is transplant still necessary? Question number 2, what is the best so-called triplet combination? And question number 3, are we actually now going to quadruplets? We saw for many years that 2 drugs worked. Well, we found that 3 drugs worked better. And we're right now in a transition where we're determining if 4 drugs are better. And actually, Dr. Voorhees has been one of the world leaders in this, demonstrating to us that sometimes 4 drugs works better than 3 drugs. So if I were to answer these questions simply, is transplant still necessary? Yes, even with all these new drugs, we're still finding, we just had a major trial presented at our big cancer meeting a couple of weeks ago, that transplant still helps gets people disease down and keeps it down for longer. So we still use, not in every patient, but in eligible patients, autologous stem cell transplant either now or deferred. And sometimes it's okay to defer. We've heard from Yelek today, he's deferred a transplant now for 25 years. I'd say that's a pretty good deferral. And so it may be something that's not necessary up front. Number two, what is the best triplet? We've learned that actually we can use both. We can use what's called VRD or Velcade Revlimid dexamethasone, or KRD, Kyprolis or carfilzomib Revlimid dexamethasone in certain patients. And though it's still maybe a little early, I think we all feel that before we do our next Empower Charlotte workshop, I think we are going to be seeing quadruplets or 4 drugs used for patients before they go to transplant. So on the transplant eligible, we're likely transitioning to quadruplets. Transplant still has a role. It's still a little bit unclear how much treatment we should give people right after a transplant, but we are giving people what's called maintenance therapy, or something to maintain that response, or what we sometimes call remission after they've had a transplant. And then lastly, what do we do with transplants who are patients who are transplant ineligible or not going to transplant? And the 3 questions are as follows. Are triplets better than doublets? How long should patients be treated? And how can we make these combinations more tolerable or better? Well, I think we have learned that triplets are better. When patients can be given 3 drugs instead of 2, we have seen better outcomes. Our chair of the board and chief scientific officer, Dr. Brian Dury, he led one of these big trials to show this to us. And we have seen indeed that given correctly, these 3 drugs work better than 2 drugs for patients not going to transplant. And in general, we try and treat continuously, as it were, where we give people, now I don't like looking at patients and saying, you're going to take it and you're going to like it and we're going to give you it forever. We'd love to be able to develop so-called stopping rules. But right now, we've learned that even if we dose reduce, it's better to keep people on longer term treatment. And then lastly, yes, we can make these drugs more adjustable for people's quality of life. I always say, I don't treat myeloma. I treat people. And I want to look at patients as people. And I want to make sure that their quality of life as much as possible is maintained. And so it becomes really critical as to exactly how we do that. So to conclude, in transplant ineligible patients, there's really a lot of similarity now between how we treat all patients up front. I think we're going to see a little less stem cell transplantation in patients who are 65 to 75 because we have so many of these new good triplet combinations. Giving people continuous therapy has been better. We always have to balance efficacy and toxicity, especially when it comes to drugs like steroids. I haven't talked much about those already, but those are the drugs that kind of boost the effect of our treatments for myeloma. And we're learning that we need to turn those down very quickly, especially in transplant ineligible patients. So we're typically using a 3-drug combination, but before long turning down the dexamethasone. And as I mentioned before, it may not be too long that we're going actually to quadruplet combinations. So just to give you a flavor, look at all of this choice. Dr. Voorhees is going to be focusing on the latter part of the slide, but I wanted to overwhelm you with the number of drugs on this table, that we have seen such a growth in opportunities for patients. This is what research does. It provides opportunities for us to have more choice for our patients so they can live better, and indeed they can live longer. So I'm going to stop at this point and thank everyone for listening to me drone on for so long about so many issues.